All right, there we are. All right, so thanks for coming to the talk again. The goal for putting together each of these lectures as part of the virtual sub-I is basically just to give you information that you can use both on your sub-I and help you get ready for your residency in the first and second years, especially under pediatrics rotation because there is such a wide array of pathology. It's often very easy to kind of fall into the trap of giving very broad differentials, kind of not recognizing the more rare pathologies. And pediatric neuro-oncology is a field where it really pays to have a nuanced differential diagnosis. And by knowing a few of the key pathologies in each region of the brain and by different age groups, you can really make yourself shine on your rotation and better understand what comes next in the workup of pediatric brain tumors. So the outline for today is I'll briefly talk about the basics, kind of what to worry about in the acute setting when you first see one of these patients based on how sick they appear. And then we'll talk about some different pathology based on location and age groups. We'll go through different case examples, talk about key imaging features, and in a couple of instances, we'll talk about molecular neuropathology of a few tumors. This tends to count a lot more often in pediatrics than it does in the adult world, where most people are more familiar with the pathology. So, because of the very wide range of pathology in pediatric neuro-oncology, it pays to know what's common in each age group and in each region of the brain. You know, in adults, we're used to seeing gliomas, meningiomas, schwannomas. They account for the vast majority of pathology that gets treated in the adult world. The number of tumors in the pediatrics world is much larger. And it pays to know them so that you can better predict the workup when a patient presents acutely. This is necessary to know whether the patient needs surgery at all, and if so, how you should go about approaching it. The way I think about these tumors when I first see them is that kids are resilient until they're not. If you look at the image on the right, for instance, this young child has very severe hydrocephalus. There is a very wide dilation of the third ventricle and the temporal horns, but we don't really know what to do about this patient until we have an idea of the acuity. You know, is this someone who's been percolating along for 6 weeks and now they're kind of sleepy and they're coming in for a scan? Or is this someone who became comatose acutely? Maybe they had a high-grade tumor that suddenly bled and this hydrocephalus is acute. We really don't know until we have an assessment of the patient. So always know what the clinical course of the patient is so that you can know whether or not this patient needs to be intervened upon emergently, or if you can kind of step back, take some time, and focus on the workup a little bit more. So this is how I like to think about pediatric brain tumors. It's mostly by anatomy. Anatomic region tells you a lot about how to narrow down your diagnosis, but it's also very different by age group. So I'll start out by talking about, the major posterior fossa pathology that you need to be familiar with and how to accurately differentiate them on the front end. And then we'll gradually work our way up from the posterior fossa. We'll talk about pineal region masses, suprasellar tumors, and then other tumors of the midline brain parenchyma, a specific subgroup of midline gliomas. Then we'll start to spread out laterally, talk about tumors of the supratentorial ventricles, talk about tumors that arise from the cerebral hemispheres that tend to cause seizures. And then I'll spend a little bit of time talking about some very rare tumors that tend to occur in very young children that aren't really restricted by anatomic location. So, the things that you need to know most commonly about pediatric brain tumors are the stuff that happens in the posterior fossa. This is really where most pediatric brain tumor surgeons spend most of their time. And the most common pathology is going to be medulloblastoma, ependymoma, and pilocytic astrocytoma. And just with a little bit of knowledge, you can really pick apart which one they are the vast majority of the time. Medulloblastomas, we classically say that they fill the fourth ventricle. They basically occlude the fourth ventricle, obstructing CSF outflow. Patients become acutely hydrocephalic, and then they present to you. They have abundant diffusion restriction and a lot of vivid contrast enhancement. So in their classical form, they're very easy to detect on preoperative imaging. Ependymomas have a very characteristic appearance oftentimes. They also arise in the fourth ventricle, of course, but they tend to kind of creep along the surface of the brain. They kind of crawl along the ependymoma in the ventricle. And if you look closely on MRI, oftentimes they're actually kind of creeping out the foramen of Volushka out of the fourth ventricle proper. They do tend to enhance, but it's a little more patchy, and they don't really have much diffusion restriction. And if it's so, it's kind of coarse and not very uniform as it is in medulloblastoma. The third major posterior fossa tumor that's very common in kids that you should be able to pick out early is a juvenile polycytic astrocytoma, or a JPA. These tend to be intraparenchymal, and they often present as an enhancing nodule with a large cyst associated with it, which may or may not have some contrast enhancement. So let's go through some examples of these so that you can kind of start to detect them. This is a 6-year-old boy with a headache and nausea, vomiting. Initially had a CT scan and then proceeded to get an MRI. So on the top left here, you can see some um, kind of, I would say, medium grade contrast enhancement. But if you look at the sagittal T1 sequence, you can see that this really fills the fourth ventricle. There's no room for the CSF to get out anymore. We can really better tell whether this is medulloblastoma or ependymoma, not only by this classic morphology of how it fills the fourth ventricle, but by looking at the diffusion restriction. You can see that the diffusion restriction is very uniform. This is obviously a DWI scan, and this is the ADC scan, to where we can tell whether this is, quote unquote, true diffusion restriction. And you can see it's pretty uniform. So this is a slam dunk for a medulloblastoma in a child. Here's a similar example. A little bit more contrast enhancement in this image. In the top right corner here, you can see that it doesn't really creep out the foramen of Luschka. It's still centered in the fourth ventricle, and it kind of stays there. Similar to the last case, with the exception of this centrally necrotic portion here, there's uniform diffusion restriction that does pan out on the ADC. Now compare that. Oh, excuse me. Now this is just here to show you that I've shown you some classic cases of medulloblastoma that really fills the fourth ventricle, but that's not always the case. These can arise more laterally in the cerebellar hemispheres or in the cerebellar peduncles here, shown in the top left. And this really has implications for the molecular subtyping of the tumor. Medulloblastoma was really the first pediatric brain tumor to be characterized on a molecular basis. And this pans out in terms of the anatomic origin of each of these tumors. They have different developmental origins. Most of the ones that we see in kids tend to be group 3 or group 4, and these are the ones that we think of as filling the fourth ventricle. If you do notice one in the lateral cerebellar hemisphere, it tends to be of the sonic hedgehog variant, which tends to have a little bit better prognosis depending on the age, or in the middle cerebellar peduncle. These tend to be what we call Wnt subtype or wingless subtype. These kids have an excellent prognosis overall. There's even a clinical trial recently where they tried to downgrade the amount of radiation these kids receive to limit the adverse effects of radiation that these kids receive. Now compare that to this child. So this is a 2-year-old boy who initially presented with headache, nausea, vomiting, similar story. But if we look really closely here at this axial image, we can see some very heterogeneous contrast enhancement. There's this centrally necrotic portion here, but this one is really starting to creep out the foramen Luschka and crawl around the front of the medulla. This is much more characteristic of an ependymoma. This really pans out when we look at the diffusion restriction in the ADC. There's maybe a little bit of diffusion restriction here, consistent with a very highly cellular tumor, which this is, of course, but it's much less uniform than it is as seen in a medulloblastoma. So here's another ependymoma. This one is really eccentric to one side. You could say that, yes, this is filling the fourth ventricle, but much more characteristic is the way it's just crawling out around the brainstem, out of the foramen Luschka. And in this instance in particular, you can see it is abutting the internal acoustic canal and abutting the 7-8 complex. So this is much more characteristic of an ependymoma than a medulloblastoma. So the third bad guy, the posterior fossa, and the one that's probably most common overall is JPA, your pilocytic astrocytoma. So this is a 12-year-old girl who presented to the emergency department. She had a headache, she was sleepy, they got a CT scan, and based on those findings, she got an MRI. So this demonstrates kind of a nodular, highly contrast enhancing mass in the cerebellar hemisphere with a very large associated peripheral cyst. In this particular instance, the cyst isn't demonstrating any mural enhancement, but based on the size of the cyst, the commonality of the disease, and this nodular enhancement, we were fairly certain this is a JPA before surgery, and sure enough, that's what it is. So here's a more extreme example. JPAs can be quite large because the cysts tend to fill with fluid over time. This is a 6-year-old girl who presented with nausea and vomiting. And you can see this enormous posterior fossa cyst that basically completely obliterates the cerebellum. There is this nodular mural enhancement here where the tumor probably began. And unlike the last case, you can see a lot more mural enhancement along the cyst wall here. So this probably does contain tumor. This is one of the primary challenges in treating a JPA surgically, is that there's a question of, do you take out the cyst wall or not? And if there's area of contrast enhancement, the answer to that question is usually yes. So let's start working our way up here. The way I think about pineal region tumors is what's there. You think about the cells that are living in the pineal region and how their progenitor cells can cause tumors. The cells that are there are either of glial origin, pineal parenchymal origin, or they're coming from germ cells. Pineal parenchymal tumors come in a wide range of flavors. I won't really get into pineocytomas or primary pineal parenchymal tumors of intermediate differentiation. Those are much more common in adults, so I'll leave those alone for now. Pineoblastomas are much more common in kids. They tend to occur in younger children, less than 5 or 6 years of age. And this is a surgical disease. They require surgical resection to the extent that it can be achieved. Germ cell tumors tend to occur in slightly older children, young adults, males more common than females, and these generally do not require surgical resection. You want to catch these on the front end, and you want to refer these to the neuro-oncologist so that they can initiate chemotherapy. These sometimes require resection if there's residual tumor or if the tumor differentiates over the course of treatment, a condition that we call growing teratoma syndrome. But these are patients that you really want to avoid surgery if at all possible. The third major subgroup of tumors that can arise in the pineal region are gliomas, of course. These are often JPAs, or these grade 1 astrocytomas that occur elsewhere in the brain, but they're not always that same grade on pathology. When they occur here, they can be on the optic pathway glioma spectrum. The superior colliculus lives there. So it's important to know that you're not just dealing with germ cell tumors and primary pineal tumors when you're considering tumors in the differential for a pineal region mass. These are really difficult to differentiate based on imaging alone. So the workup really hinges on the demographic information of the patient, as well as some lab work that you get beforehand. So if I tell you all these look alike, this is what you have to do if you are evaluating a patient with a pineal region tumor. You start with a medical workup. And the idea is to determine whether or not this is a germ cell tumor that might respond to chemotherapy. So you want to give serum and CSF germ cell markers, including beta-HCG, alpha-fetoprotein, and placenta alkaline phosphatase. If those are positive at all, meaning they are excessively high in any pattern, then usually the neuro-oncologist can proceed with treatment without a tissue diagnosis. And this is great. This means we don't even have to touch the patient. More often than not, though, they tend to be kind of intermediate or equivocal or not present in any characteristic pattern. And in this case, it really requires a tissue diagnosis. So how do we go about doing that? We have a really elegant way of getting a tissue diagnosis, getting CSF, treating all of the patient's problems at once if they have a germ cell tumor. Some of you may have seen this on your rotations or may otherwise be familiar with it. This is a paper that kind of demonstrates how these authors do an endoscopic third ventriculostomy. So in this procedure, you can oftentimes just make a single burr hole, pass an endoscope into the right lateral ventricle. And in this image, you pass through the foramen Monro underneath this structure here, which is the fornix, and you identify the mammillary bodies, and you come through the floor of the third ventricle just anterior to those to create a new pathway for CSF to flow. This is obstructive hydrocephalus, so the vast majority of the time, this is an efficacious way to treat hydrocephalus without having to place an indwelling catheter. Now, based on your biopsy results, the pathologist will be able to tell you whether or not this is a germ cell tumor, meaning whether or not any further surgical resection is necessary. So here's some examples of different pineal region tumors. As I mentioned, they do tend to look similar, but what are you looking for? This is the first example. This is a 6-year-old boy who presented with what his parents perceived as behavioral disturbances. He got a CT scan and subsequently an MRI, and you can see that there's this heterogeneously enhancing mass that's centered in the pineal region and extending forward into the third ventricle. I haven't done a good job kind of displaying secondary hydrocephalus here, but he was mildly hydrocephalic and we needed a tissue diagnosis. This ended up being a pineoblastoma, and he proceeded to surgical resection. So compare that patient to this. This is a 14-year-old male with nausea, vomiting, and also present as a heterogeneously enhancing tumor of the pineal region that is kind of difficult to differentiate based on imaging. I haven't gone through the whole gamut of diffusion-weighted and T2-weighted imaging because there isn't a whole lot of difference between these two tumors. What is different is the age of the patient. This is a young adult. He's a male. So germ cell tumor kind of creeps up on your differential a little more than before. Here's another example of a germ cell tumor in a young male. This is a 14-year-old boy who presented with nausea and vomiting. He underwent an endoscopic biopsy and was found to have a germinoma with a component of a mature teratoma. And in retrospect, we could have predicted this. This is a CT scan that he got as part of his initial workup, demonstrating this small area of calcification, which is a feature of a teratoma. So the tissue diagnosis bore that out ultimately. So compare those last two cases to this. This is a pineal region low-grade glioma. This is a 15-year-old boy who had several years of difficulty at school. He was starting to fall behind his peers, and eventually someone thought that they should get an MRI to evaluate this. What no one had really investigated before is the fact that he had a very large head circumference. You can kind of tell that the size of his skull is out of proportion to the amount of brain matter that's in it, and that's due to obstructive hydrocephalus from this tumor. In someone who is cognitively normal with no diminished level of consciousness and obstructive hydrocephalus, there's usually an indolent pathology underlying this. And sure enough, that's what this was. This was a grade 1 pilocytic astrocytoma that had very gradually caused obstructive hydrocephalus over many years. There's not much contrast enhancement, but consistent with other pilocytics that you see elsewhere in the brain, there's just a little whiff of contrast enhancement here. Nothing else to suggest a high-grade tumor. So we'll keep moving superiorly and forward. In the Sellar and suprasellar space, most of you are familiar with the Sachmo mnemonic here, of course, standing for sellar mass or pituitary adenoma, aneurysm, teratoma, craniopharyngioma, hamartoma, meningioma, and optic pathway glioma. So this is what most people will kind of rattle off whenever they're listing a differential for masses in the suprasellar space. And in kids, you can really narrow down the diagnosis if you just know a few key imaging features. You can make yourself look a lot smarter. I'll focus on the three that are much more common in kids and that you'll probably see at some point in your practice: so craniopharyngioma, different variants of optic pathway glioma, and teratoma. Cushing adenomas can happen in kids. I've seen a couple. They're often imaging negative, so they require laboratory diagnosis. Because this is largely a radiology-driven talk, I won't get into the imaging on these patients here. So here's our first suprasellar mass. On this T1 weighted MRI with contrast, if we zoom in on the suprasellar space, we can see this region just above the cella with some heterogeneous contrast enhancement and this very large associated cyst filled with proteinaceous material. So here's the ventricle here. Here's the intensity of CSF. You can see that on T1 weighted imaging, it looks thicker than that. The cyst wall has some contrast enhancement. And if you go back and look at the CT, which she had beforehand, you can see that there are these speckled areas of calcification starting in the sella and extending up where the tumor resides above the sellar space. So this is extremely characteristic of a craniopharyngioma. If you have a young adult, or sometimes an older adult, but less commonly, with a calcified suprasellar mass associated with a cyst, it's a craniopharyngioma 99 times out of 100. So here's another example, very similar case. There's kind of a tiny nodular heterogeneously enhancing mass that begins in the suprasellar space, and it is associated with this fairly large cyst that extends up into the third ventricle, also with some mural enhancement. Now, on a CT scan or susceptibility weighted imaging, if you got that sequence with the MRI, you can see some speckled calcification, again, which is highly suggestive of a craniopharyngioma. Now compare that case to this. This is also a suprasellar tumor. It's enhancing, but it's much more uniformly enhancing. And you could be forgiven for saying, oh, this is a young person with an enhancing mass in the suprasellar space. Maybe it's a craniopharyngioma. But there are a couple of things that rule that out. One is the age. The person's a little young to have a craniopharyngioma. It's happened before, but it's less common. And the second feature is this. If you zoom in on the optic nerve on the left side, you can actually see that the tumor tracks along the optic nerve. This is an enhancing tumor, and you can see it starting to wrap around the nerve sheath on the left side. So based on the imaging alone, we could tell that this is an optic pathway glioma. Now, these can occur anywhere along the visual pathway, from the optic nerve all the way back to the cortical regions where vision is represented. Here's an example of another suprasellar tumor, also vividly, homogeneously contrast enhancing. And the radiologist actually told us that this was a craniopharyngioma. It's a 13-year-old girl with an enhancing suprasellar mass. Why wouldn't you think so? However, when we look back at the coronal sequences, there's a strong hint that maybe that's not what this is. One, there's no cystic component. There wasn't any evidence of calcification. And if you follow this tumor back along the optic gradations as they go into the lateral geniculate nucleus, that's much more suggestive of an optic pathway glioma. And that is what this ended up being. So here's a very characteristic pathology of young childhood. This is an example of a teratoma. This is a 16-month-old boy who his parents thought had been kind of sleepy. He was starting to sleep more during the day. He eventually got a head ultrasound, and they picked up something unrelated on the ultrasound and sent him for an MRI. And they found this. This is a plain T1 sequence in the sagittal plane from an MRI on this patient. You can see this vividly hyperintense region of signal on T1 weighted imaging here, and that's very characteristic of fat. So teratomas characteristically have a fair amount of fat and calcification. So the neuroradiologist saw this and thought, well, let's ensure that that's fat. They can perform a fat saturated sequence, and when they subtract out the signal of fat, that region disappears, confirming that it's fat. That tells us that this is a teratoma. Under other circumstances, if this child were older, for instance, you could look at this area of calcification on susceptibility weighted image and say, oh, this is a calcified suprasellar mass, but the age is all wrong and there's fat in this tumor. So this is a teratoma. I lifted this image from Radiopedia because it was such a good example. In this image, the teratoma is mostly consistent of fat. You can see all of this very bright T1 weighted T1 hyperintensity here, all of which suppresses on fat sat imaging. This is an excellent example of a teratoma. So the last batch of tumors I'd like to touch on that reside in the midline are a special class of tumors called midline gliomas. This batch of tumors includes the previous pathologic entity that was known as DIPG, or diffuse intrinsic pontine glioma. Nowadays, molecular diagnosis is often necessary if they want to be very specific about the diagnosis, but often it's made on clinical imaging alone. Now, according to the WHO classification nowadays, it's classified by the presence or absence of this characteristic mutation, H3K27M, which I'm sure a lot of you have heard about in your research or in your sub-Is. This refers to mutations in one of several genes coding for histone subunits that block the ability of a lysine residue at position 27 to be amenable to epigenetic modifications, such as acetylation and methylation. The end result of this is that there is a complete loss of H3K27 trimethylation. And even when this mutation is absent, the absence of this methylation portends a poor prognosis. So this is very interesting from a molecular biologic standpoint, and it's clinically relevant nowadays. There's no efficacious treatment for this tumor because of its location. It's not amenable to surgical resection. But in cases where the clinical diagnosis is uncertain, we as neurosurgeons can step in and offer a tissue diagnosis. So this is a pretty characteristic example of what used to be called a DIPG, or an H3K27M-mutant diffuse midline glioma. So this is an 8-year-old girl who presented with double vision. And in this top left image here, you can see a T2 hyperintense mass that is encasing the basilar artery. In the days before we really understood the molecular feature of this tumor, this was sufficient for diagnosis, and it still often is. Another characteristic feature of this tumor is that it tends to follow the long tracts. So you can see here it's creeping up into the pons. The pons is starting to have a more fat appearance and crawl around the edge of the basilar artery. It extends up into the midbrain and even to the up toward the thalamus on the left side. This is very characteristic of a DIPG, but in this case, the diagnosis wasn't certain, and there was this large exophytic component that was amenable to biopsy. So she proceeded to biopsy, and sure enough, she had an H3K27M mutant diffuse midline glioma, or as we would call it, a DIPG. So let's get out of the midline, kind of spread out laterally, and talk about some other intraventricular tumors, specifically those that are not found in the posterior fossa. We'll talk about subependymal giant cell astrocytomas, as well as some choroid plexus tumors. SEGAs, or SGCAs, are characteristic enhancing lesions near the foramen Monroe. They also have calcification, and they're almost always found in concurrence with other manifestations of tuberous sclerosis. It used to be that this was sufficient for the diagnosis. It's not quite that way anymore, but if you see a subependymal giant cell astrocytoma, look for other manifestations of tuberous sclerosis just to make the diagnosis a slam dunk. So here's an example of a SEGA. So you can see this avidly enhancing mass arising at the foramen Monroe. And this image is particularly nice because it shows you some nice anatomy near the foramen. So this is an image of the venous angle. This is the internal cerebral vein here. And this is made up of venous drainage that the ICV receives from the thymostriate vein and the anterior septal vein here. Here's a schematic just for your reference. This was a 14-year-old female with a headache. So in this age group with these imaging features, this is going to be a SEGA 99 times out of 100. Now, in this particular case, she actually didn't have any other intracranial manifestations of tuberous sclerosis. So let's see what that looks like. So here on the left side is a 6-year-old boy who presented with a headache and disconjugate gaze and eventually got a head MRI. Similar to the last case, he has this very avidly, homogeneously enhancing mass at the foramen Monroe on the left side. But if you look at T2 weighted imaging, you see these areas of T2 hyperintensity in the cortex, especially as you get up close to the vertex. These are actually cortical hamartomas called tumors, and these are what contribute to seizures that are so characteristic of tuberous sclerosis. On the right-handed side here are images from a 4-year-old girl who had known epilepsy as well as numerous other manifestations of tuberous sclerosis, including these angiomyolipomas of the kidneys. She had a rhabdomyoma in her heart. And she doesn't have one of these big honking tumors near the foramen Monroe, but she does have these small subependymal nodules of the lateral ventricle. She had one near the foramen Monroe on her right, and then she had two more on the left that were a little bit further away. These are subependymal nodules, and they may or may not be found in conjunction with one of these larger tumors here. And from a molecular standpoint, they're the same. And they can be treated as subependymal giant cell tumors. It's just that they're not near the foramen Monroe. However, even in this patient, there was a characteristic lesion near the foramen. So always keep that in mind when a SEGA is on your differential. So compare that patient to this. Now this is another teenage girl who presented with seizures, but this tumor is very different in location and appearance. So here we have another homogeneously enhancing mass, but this one is arising much further lateral in the lateral ventricle and the temporal horn. In addition to the contrast enhancing features, you can see that it's occluding CSF outflow from the temporal horn of the lateral ventricle. These tumors tend to do that and cause what we call trapping of the temporal horn or local hydrocephalus. These can occur any time in childhood. This is a 5-month-old girl actually who was brought in for difficulty feeding. She was noted to have an enlarged head circumference, and so she got some brain imaging. And this demonstrated a heterogeneously enhancing mass in the left lateral ventricle that was actually extending much further up, also causing occlusion of outflow from the temporal horn, as in the last case. Now, this one is much less uniform appearing. It tends to kind of feather into the white matter here. So this one has a higher grade appearance. We actually weren't sure whether this was a choroid plexus carcinoma or not on the front end. And just to give you an idea of why we were concerned about that, here's an example of a choroid plexus carcinoma. So this is another tumor of young childhood. This was an 8-month-old girl who presented with weight loss and lethargy. Now, compared to the other tumors, you can tell that this arises in the lateral ventricle. It does not appear to be arising in the white matter and protruding into the ventricle, for instance. This is clearly an intraventricular tumor that is expanding out into the brain. We don't have a contrast-enhanced sequence for this, but we can tell that this is probably much more likely to be a higher grade tumor based on the heterogeneity of appearance. You can tell that it doesn't have a uniform structure. It tends to be locally invasive. And sure enough, this ended up being a choroid plexus carcinoma, which fit with her age and the imaging features. Now let's move even further out laterally and start talking about some tumors of the brain parenchyma proper. I like to think of all of these as tumors that cause seizures. Compared to the other tumors that we've looked at, which tend to present with focal neurologic deficits or hydrocephalus, these parenchymal tumors are much more likely to cause seizures and impair quality of life. They're on the spectrum of low-grade tumors of glioneuronal differentiation, and they also include this tumor down here, a pleomorphic xanthoastrocytoma, or a PXA. In general, these are worked up according to seizure protocols, and you can usually tell what they are on the front end if you just know a few key imaging features. The first of the seizures is a DNET, or this dysembrioplastic neuroepithelial tumor. Oftentimes they have this characteristic bubbly appearance on T2 weighted imaging, and they don't enhance. Gangliogliomas are also low-grade glioneuronal tumors, but they're small, they avidly enhance, and they have these small peripheral cysts associated with them. Now, this can often be confusing because this it looks very similar in appearance to another tumor that can be grade 2 or 3 called a pleomorphic xanthoastrocytoma. These may also have a peripheral cystic component, and so you need a tissue diagnosis to differentiate it from this grade 1 tumor, which can be cured with surgery. So here's what a ganglioglioma looks like. On the top here, there's an 11-year-old boy who presented with complex partial seizures, and he got an MRI. You can see this homogeneously, avidly enhancing lesion located peripherally, associated with this relatively small cyst, and this was in the parietal lobe. Similarly, here's another patient, a 17-year-old boy who also presented with a seizure, and a very similar appearance. This is very characteristic of a ganglioglioma. To compare that to this patient, this is a 10-year-old who also presented with seizures, but the imaging here is very different. There's no contrast enhancement, as you can see on this T1 weighted contrast enhanced image here. But on T2 weighted imaging, it has this bubbly appearance. Even though there's no contrast enhancement, the macroarchitecture of this tumor is such that you can usually make a diagnosis preoperatively just by knowing that there's no enhancement, and it tends to look like there are bubbles coming out of the brain. So the third of the seizure-producing tumors in this heuristic that I like to think of is a PXA. Here's an example of what a PXA looks like. This is a 16-year-old girl who presented with a complex partial seizure. So similar to a ganglioglioma, there's this region of homogeneous contrast enhancement, but this looks a little bit different. There's this peripheral component that's not enhancing. So a surgery was really necessary to determine whether this was a ganglioglioma or a PXA, which is a grade 2 or 3, something that we have to worry much more about recurrence. Some characteristic features of this tumor are leptomeningeal tracking. I didn't have a great example of this personally, so I lifted this off AJNR. This tumor occurs very peripherally, and it tends to spread out and crawl along the leptomeninges. Sometimes this can be so dramatic that it gives the appearance of a dural tail, which you can see in this bottom left image here that I stole from Radiopedia. Otherwise, they do tend to look like gangliogliomas, but sometimes you get lucky and you find this telltale sign that this is probably a PXA by how it crawls along the leptomeninges. So the last category I'll talk about today is kind of a grab bag of other tumors that aren't really restricted by anatomic location, but all have in common the fact that they occur in very young children. In addition to the tumors we talked about already, whenever you're dealing with someone less than 2 years of age, always keep these rare diagnoses in mind. These tend to have a very high grade or low grade appearance. And for the high grade tumors, these tend to be embryonal tumors of different flavors. They can have a variable appearance, but they have in common that they're often quite large and invasive at presentation, often causing acute hydrocephalus requiring emergent intervention. The first tumor in this category is ATRT, or atypical teratoid rhabdoid tumor. It has a characteristic histopathologic appearance that resembles muscle cells. That's why they call it a rhabdoid tumor. And the second is a grab bag of tumors that used to be called PNETs. One example of this is what's called an ETMR, or an embryonal tumor with multilayered rosettes. It's an exceedingly rare tumor that's in this category of primitive neuroectodermal tumors that the WHO no longer really uses to classify tumors. I'll talk about an additional benign tumor that we haven't touched on yet, and this is called a desmoplastic infantile ganglioglioma. These have a very characteristic imaging feature of an enhancing mural nodule with enormous associated cysts that are very characteristic of the diagnosis. So here's an ATRT. So I mentioned before that anytime someone is less than 2 years of age, there are always a few things you got to keep in mind. So we can see here that in this case, there is a heterogeneously enhancing mass. It's originating in the left temporal lobe. On this T2 weighted image, you can see it's encasing a lot of the middle cerebral artery branches. So it's high grade, it's invasive, and it's in a very young child. In that case, an ATRT has to be on the differential, and that's what this was. So here's another example of an ATRT, a little bit more characteristic. This was a 2-year-old boy who presented with acute vomiting and had been having gait instability for a few weeks. You can see a heterogeneously enhancing mass with a large area of central necrosis, indicating that this is a very rapidly growing tumor. Whenever he presented, he got full neuraxis imaging, and this demonstrates leptomeningeal spread. I'm sure you've all heard of it at this point, but that's what this looks like. It's normal to have a little bit of contrast enhancement on the surface of the spinal cord, what we call peel enhancement, but this is what we would call, quote, cake-like, end quote. It kind of looks nodular. It looks like someone took icing and just kind of spread it all across the surface of the cord. So this obviously portends a poor prognosis, and it's important to know this before you begin to recommend surgical resection for these patients. It's important to stage them. Here's a third example of an ATRT. So this one looks quite different. This is also a tumor in the pineal region, but this is a 10-month-old boy. So we have to keep ATRT and these other embryonal tumors in mind. He presented with rapid onset hydrocephalus. He became sleepy one evening, got a CT scan, and it showed severe hydrocephalus. We could tell at the time that it was acute because he had no evidence of transependymal flow. So this is all consistent with a very aggressive, rapidly growing tumor. On this tumor, on this sequence here, you can see that it's a very heterogeneous tumor. It has like a partially cystic and partially solid component. And more striking was the degree of vascularity. This is a susceptibility weighted image, and this is all representative of hemoglobin in the tumor. So this is an intensely vascular high-grade tumor. All of these are different features that may be present in ATRT and can give you a clue that you're dealing with a very aggressive embryonal tumor. So here's an example of one of the quote PNETs that we don't really use that term for anymore. This is an ETMR. These are exceedingly rare tumors. I actually don't have one on record, so I lifted this one off Radiopedia. They're very difficult to diagnose preoperatively just because they are so rare and tend to not have characteristic imaging features. But like ATRT, they tend to be very large, they tend to be very heterogeneous, and heterogeneously contrast enhanced. A tissue diagnosis is really necessary to know what you're dealing with when you're working with a PNET. So here's that benign, quote unquote, pathology that I mentioned earlier. This is what a desmoplastic infantile ganglioglioma looks like. These are avidly uniformly enhancing tumors that can arise anywhere in the supratentorial compartment, and they cause symptoms when their cysts get so large as to compress the brain. These cysts can be extremely large, and this is actually almost diagnostic of the tumor even before surgery. So here are two more examples here. You can see one that's located peripherally, but it shares in common with the last case this large cyst that's protruding medially. This child was a 5-month-old girl who was noted to have an enlarging head circumference on a routine PCP visit. Similarly, here's a 5-month-old boy who went from the 50th to the 90th percentile in head circumference and was found to have this conjugate gaze by his parents. These aren't invasive tumors, but because of where they arise, they tend to envelop local nerves and arteries, which can make surgery a morbid endeavor. This cyst here tended to be less predominant, but it also gave us a clue on the front end that this was going to be a DIG. All right, so that's how I like to think about pediatric brain tumors. Hopefully when you see some of these lesions on your pediatrics rotation, you have some insight into how to develop a really specific differential and what comes next. It's 10:02, so I'd be happy to go ahead and take any questions that you might have.
Hey, Cody, this is Dave Daniels. Thank you very much for going over that. So again, thank you everybody for joining this week. For those of you that were there last week, you probably remember me. I'm one of the pediatric neurosurgeons here, specializing in brain tumors. And so I can see that that's a hit parade of some of my good cases that Cody presented. So I can tell you that one of the more rare tumors that he presented with 3 of them is the ATRT, which tells you that Cody's interested in studying those tumors because that was disproportionately represented there. But Cody's studying that tumor in the lab, trying to figure out what makes that tick. I think I've operated on 3 ETMR or PNETs my whole time here. So that's 7 years. That's one every other year. So that's how rare those tumors are. So anyway, nice job, Cody. If anyone has any questions, please feel free to ask them now. And again, like I said last week, our email address is please reach out to us. It's just in our last name dot first name at mayo.edu. And again, mine is daniels.david@mayo.edu and so on and so forth. So
I have a question. Oh, sorry.
Go ahead, Miguel. Sorry.
Thank you. Dr. Cody, I have a question. Which one of the tumors that you talked about today have the highest rate of recurrence? And would you consider for the tumor that has highest rate of recurrence to place a VP shunt, or in case they recur?
It's a good question, and a lot of them have very high rates of recurrence. You know, when you look at the Kaplan-Meier curves for a lot of the high-grade tumors that we discuss, you know, it goes like this. And the further you move to the right, the more kids drop off the curve because of local recurrences. A lot of them do get VP shunts, and that's kind of a mixed blessing. It does kind of temporarily treat the CSF, but they tend to occlude. And in extreme cases, if there's CSF seeding, you're introducing the possibility of allowing the tumor to spread to other parts of the body. You know, for those two reasons, we try to avoid VP shunts if at all possible, but hydrocephalus often persists even after you take the tumor out. So it's a necessary evil, is how I would describe it.
Thank you.
Hi, I'm really interested in the ATRT. We talked about how it had some vascularities. Are there any therapies right now that are geared to like an anti-VEGF or trying to like knock out those vascularities to slow down that growth?
Yes, and that's not a characteristic feature of ATRT specifically. It's just a general feature of a lot of high-grade tumors. That was a particularly striking example that I thought might kind of give you an idea of what that looks like. Anti-VEGF therapy has been tried in glioblastoma. It doesn't have, you know, we have some trial data for that, and it doesn't prolong survival. It does make the imaging look better, and it does treat a tumor-associated edema. But the only efficacious therapy for ATRT is going to be combination cytotoxic chemotherapy with local radiation and craniospinal irradiation, with or without hematopoietic stem cell transplant. So that's kind of the gold standard for treatment of ATRT, as well as some other embryonal tumors. Farhan, I think you had a question. Is that right?
Oh yeah, just a question on, so like if you have a patient who's asymptomatic, macrocephaly, and like a child infant, and what would be your initial kind of threshold that you would say, okay, we need advanced imaging here, we need like an ultrasound maybe, or do you want MRI or CT scan? Like what is the kind of like algorithm you guys implement for these kind of kids who are asymptomatic but with macrocephaly, new onset of macrocephaly?
That's a great question. And the important thing is the trend. So like me, for instance, my kids are going to have big heads, and that's just how it is. But for the children who have worsening macrocephaly, you know, they were at the 50th percentile, and now they're at the 80th, and then they come back again, and now they're at the 97th percentile. That's obviously abnormal. In that instance, you would say, let's get an image. It's much more easy to detect in kids with an open fontanelle. And in that instance, you might be able to get a head ultrasound, which is cheap, doesn't involve any radiation, doesn't require sedation. If you're dealing with an older child in whom the sutures are fused, then at that point you have to start thinking about an MRI. Usually, in those patients, there is some other neurologic deficit in association with an enlarging head circumference. But by that time, you know, it becomes much less common because the sutures have been fused. Does that make any sense?
Yes, it does. Thanks. I guess I have one more question. I guess quick off that. So I know you guys at the Mayo Clinic kind of one of the pioneers of the proton beam therapy. What kind of tumors have you guys used in pediatrics for the proton beam therapy now? I know you guys did it with Medulloblastoma. What other kind of tumors are you guys treating over there? Because I've never had exposure in Detroit. I've never seen that type of therapy used here. So.
Sure. Cody, I'll just briefly take this. This is Dave Daniels. So the proton has been tried for pretty much any tumor for radiation in kids. I can say we use it probably for every tumor in kids, except the one exception is the GBM or the high-grade midline gliomas. The benefit of proton is that drop-off effect of the radiation. So the thought is you're going to have less injury to the normal brain. And so that's very helpful in a growing, developing brain. And so, we have even talked about using it for proton but again, it's a expensive resource per se. And so the people that we know aren't going to have a long-term potential are the ones that we would withhold proton from. Everybody else gets it. So I can say craniopharyngioma, proton. The ependymomas, proton. Medulloblastomas, proton. So everything pretty much gets proton, except for the DIPG style tumors or potentially even a GBM. It's a hard conversation sort of have with families of those high-grade gliomas where they're like, well, we read about proton, we want to have that. And I tell them that the proton versus photon has no efficacy difference. And in fact, we probably want the photon to be a little bit messier per se, meaning the gliomas have these fingers that reach out. And so if we have something that's very precise like the proton, we won't get those fingers. So that's not in truth, in reality per se, but I can say that that's a good explanation that the families, are comfortable with. So.
All right, thanks, sir. Anyone else have any questions? All right, sounds good. Thanks everyone for tuning in. Next week, we're going to have Dr. Kraus come and talk to us about spinal cord tumors. So if you're interested in attending, just RSVP, and we look forward to seeing you then.